having a hard time figuring out what to kind of pay attention to is the human development part. I know you kind of went over it in class, but could you touch a little bit more in depth on it?
From what perspective?
Literally any, because that's what I'm having a hard time narrowing down on.
There's nothing to narrow down. And so from the human body perspective, if you look at your objectives, you're looking at the lifespan. So what happens with infants? What happens with kiddos? What are some concerns that you would have in relation to, health as they get older? What are changes that happen? So there's not a way to narrow that down.
Okay, that makes sense. I was just trying to see if there was a way to. So if there's not, that definitely helps.
Yes, unfortunately, you have to be able to understand what's going on. What do they have? What do they not have? What systems start to fail? Which systems don't work as well? So when you're looking at that, all of those components would be a part of it. So when you go to your course board or go to eCampus, then when you click on the human body or human development, it's not necessarily human body, but human development, when you click on it, it literally goes from the beginning to the end, for lack of a better word. Would that be a fair assessment?
Yeah.
Okay. So what I would do is, what's normal things for infants? What's normal things for toddlers? Then look at school age, then look at adolescents, then look at young adults, then look at middle-aged adults, then look at your elderly or your older age, or however they categorize it. But that would be how you should follow through on that component. So, what's health promotions that you would need to do as far as making sure vaccines are done, elderly folks that have critical illnesses and immunosuppression, or they're considered to be immunocompromised, getting a flu shot and getting a pneumonia shot over a certain age. The one thing you don't have to worry about, I could tell you this, is the Erickson's, that whole, we're not doing the Erickson's stages.
Okay.
So that will help you. I mean, I can't say it's a whole lot, but that's one less thing you have to focus on.
That certainly helps. So one of the things you had mentioned during lecture was that like the vaccines that they don't get if a family member is immunocompromised.
Right. But that's under immunity though.
I guess I'm bouncing around looking at my notes. So the thing that I found in the books would be like the active flu, the pneumonia, and the MMR. Did I miss any?
Okay, say that again. I'm so sorry.
So the ones that I came across, like we wouldn't give to a patient with or a kid with an immunosuppressed family member, was like the active flu, like the nasal spray, the pneumonia, and the MMR. Did I miss any? Or are those three the main ones?
I mean, because there's other vaccines besides the flu.
Like the ones that we wouldn't give to a patient if they had an immunocompromised.
But it's not the patient, it's family members that are immunocompromised.
Yes.
Because now they would be basically toting around the live virus. And so someone that is immunocompromised, then that person already has a weak immune system. Therefore, they are more susceptible to developing the whatever vaccine that particular patient has been or have what they've received. That's the word I'm looking for.
Yeah, but my question was the active ones we wouldn't give them with the immunocompromised patients. Is it like the polio, the active flu, MMR?
Okay. Go ahead.
I was asking, are those all of them, or did I miss one?
Okay, so what does your reading say? And I could easily answer your question, but what I'm finding is that you're wanting me to narrow down the vaccines, and what I'm wanting you to do is I'm wanting you to go look for it and find it so that way you'll know for yourself, not only memorize these vaccines. Does that make sense?
Yeah. So the ones
Because
that
if
I had,
somebody got smallpox, would you want somebody with smallpox to be around a person that's immunocompromised?
no.
So
So it's
exactly. So this is what I'm saying. You don't narrow your focus on it, but there are folks you need to know about these vaccines that can now infect a person that's at home that may have been receiving chemotherapy or whatever the case may be. So you need to understand the whole scope. Nursing is not just little pockets. You have to
well,
have the whole gamut.
so I understand the fact that we don't want to give them an active vaccine. However, in the books, I was having a hard time narrowing down from finding the list of vaccines that we would give as to which ones were actually active that would affect an immunocompromised family member.
Out of Reese doesn't list that. Because that's where you would go to find that information. Is anyone else having difficulty on the vaccines?
No.
So the thing was, I had no problem finding what vaccines we would give them. It was the trying to figure out where it was posted, the active ones. That way we would know which ones don't go to a family with an immune
Well,
suppressed
I
family
think
member.
what you're looking for is a chart, and it's not. I don't believe that it is laid out in that aspect. So I think what you're looking for, this is a list of vaccines that if the baby or whoever the kiddo was to receive it, they need to be well aware that if they have someone at home that's immunocompromised, then this vaccine can't be given. I don't believe that is listed out in a chart for you in that format. I think what you actually have to do is go through there and understand that if it's a live vaccine, then what would you need to do in reference to that component? So again, smallpox, your MMR, those are the types of vaccines that you really don't want to have a kiddo receive if they're going to go home to somebody who's immunocompromised. And I think just putting those pieces together would kind of help if you understand that they have a live virus and they would now be a carrier that could potentially infect that immunocompromised patient so that now they can end up with mumps, measles, and rubella. Does that make sense? Does that help you on some level?
Yes, ma'am.
Okay. So I think if you look at it from that perspective and how immunity happens in the first place, whether it's active, acquired, though all of those different ones, is it passive, then that can also that should also help you to narrow down your focus. But it's more so when kiddos are receiving vaccines, then we need to make sure that we ask about anyone at home, especially if they're live viruses. We don't want to go home and now cause that person to have some type of adverse event. Are there any other questions on the human body or I can say human body, but human development? Okay, I can throw a couple things out at you. So, how would an elderly person present if they have a urinary tract infection?
Like AMS.
Mm-hmm.
Behaviors sometimes.
Okay, so that'd be pretty much the altered mental status, I think is what you're saying. When you're saying behaviors, are you saying combative, or are you meaning?
No, just behaviors that are not typically their norm. Like I have seen patients that start exhibiting behaviors, whether it's irritation, uh, not irritation, agitation, irritability, and that's usually the first thing we check is a UA, because 9 times out of 10 they have a urinary infection because they have a change of behavior other than that's different from their norm, is what I'm
So
trying to
basically,
say.
you're saying their normal cognition has declined.
Right.
Okay, so that would be the altered mental status. So I just wanted to make sure that that's what you meant by that. Okay, what else?
Sometimes those that are normally continent will become incontinent.
Okay.
They also get real lethargic,
Mm-hmm.
but still remain without a fever.
Okay, so usually the biggest thing is alteration in mental status. So would that include confusion?
Yes.
Yes, it would. So they're confused, or they have a decreased level of activity. So those are things that'll happen to them, and they will be afebrile. Okay, so normally when you have someone with a UTI, they will be febrile. That's not elderly. Would the same thing be applicable to pneumonia?
Yes.
Exactly. So pneumonia pneumonia and UTI. So if you have an alteration in mental status for an elderly individual that is afebrile, then those are the two areas that you would look at for an elderly to see if they have a pneumonia or if they have a UTI on some level. Okay, so what about what would be some things that you could do for a patient that has osteomyelitis? How would you support the injured extremity or the affected extremity? What would you do?
You'd want to elevate it.
Okay.
Warm compresses to help. I think it's, warm compresses. Hold on, I'm thinking of something else. Never mind.
Okay, I was about to say, I'm not really sure about that one.
I was thinking cellulitis when I heard the itis. Sorry.
Yeah, okay, that makes more sense. So basically, is that leg stable? Is it weak?
Most of the time, depending on the age, it's going to be immobilized. They're not going to be able to move it well, if at all.
Okay, so if you needed to, say, for instance, you needed to elevate the leg, how would you do that?
With like a yellow wedge, or if those weren't available, pillows.
How would you support the leg, though, before you got to that point?
What do you mean?
So you have usually most osteomyelitis is in the lower leg. So would you pick it up by the ankle? Would you just grab the ankle? How would you support the leg?
With the ankle and the knee, the whole leg.
So above and below the affected area?
Yes.
Okay. So yes, when you have someone that has, even this will be a fracture, you want to support the leg completely. So don't pick it up by the ankle and just raise it up, because now the whole leg really isn't stable. Remember, that part isn't stable either, the affected component. So when you're trying to support the leg, like if you need to reposition the patient or whatever the case may be, then you want to make sure you're supporting it above and below the affected area.
Ms. Hudson?
Yeah.
I did have a question. I was going over my note cards that I just can't grasp my head around. If we're finished with osteomyelitis here.
Oh, I was going to ask a few more questions about osteomyelitis, but go ahead.
My question is because I was reviewing some of the examples of like respiratory acidosis, alkalosis, and all that as far as acid base, and I cannot grasp why, I guess, hypoxemia is respiratory alkalosis, because I see it as when you're hypoxic that you're retaining CO2. So my brain keeps saying that it's respiratory acidosis. And so I'm not understanding, I guess, the mechanic of that. I'm missing something to keep me from kind of understanding. Same thing with like CHF, why it's respiratory alkalosis versus acidosis, because I relate CHF kind of in the same sense of when they fill up with the, with the fluid that they're having trouble.
Okay, so let's finish with we'll get to that. Let's finish osteomyelitis, and then we'll get to the acid-base balance. And I think it should clear that up.
Okay.
All right, so what type of diet would you have for a patient with osteomyelitis and why?
High protein.
Okay, high protein, anything else?
Protein's good to rebuild tissue, damaged tissue.
Is high protein the only thing you would need that would be appropriate for a meal?
Would we want them to be high calorie also?
Yes, high protein and high calorie.
Low fat and sugar.
No. High protein and high calorie. Protein for the muscle, and then
Calories for the nutrition.
for the nutrition. So when your patient goes home, and this is still on osteomyelitis, what are some things you need to talk to them about?
How to properly monitor the area for signs of recurrent infection.
Okay, I like that.
Good hygiene.
Good hand hygiene, okay. What else? Is that it?
Reinforce their diet
Okay.
when they go home.
Mm-hmm.
Proper ways to ambulate depending on their injury.
Yep. Okay. So when they go home, will they be on IV antibiotics or will they be on PO antibiotics?
A lot of
It'll
times
dep-
IV antibiotics for a period of time.
I'm sorry.
It'll depend on if they're having like a home health nurse come out to do their antibiotics. If they don't qualify for a home health service, then they'd be PO.
Does a home health nurse are they the only persons that can give an IV antibiotic?
The
Not
patient
necessarily.
not to do it.
I'm sorry.
The patient can be educated and taught how to do it.
Or family member.
Mm-hmm.
So, I mean, it'd be nice if a home health nurse, depending on, if the patient had any other needs. So, that would definitely be something that can happen. However, those patients are going to be on long-term antibiotics until that osteomyelitis doesn't go away with a couple of antibiotic medication administration. So this is going to be a long-term process. The infection is in the bone marrow, so they have to get all of that out. So for that, they would be taught how to administer medications or family member. They would also be taught about how to care for the line, because they'll probably go home with a PICC line, right?
Mm-hmm.
Or will they go home with a peripheral line?
PICC line.
It would be a PICC.
It'll be a PICC line. So, they need to talk, or we as nurses need to teach them the signs and symptoms of infection, related to the PICC line, what to look for, redness, swelling, pain upon palpation, induration, which is basically, is it hard around the catheter site, clogging, if the medication doesn't infuse into the, doesn't infuse through. So those are all things that we want to educate them about. So will the antibiotics start before their discharge or once they get home?
They'll start.
Before.
Okay, so just FYI, where I'm at, there's about to be a big old thunderstorm. So hopefully, the internet doesn't drop. I just heard a big little thunderclap out here. Okay. So, you know, osteomyelitis is a big, it's not like a simple thing, because if someone doesn't take care of it, they're going to end up losing their extremity. So that's the reason why we need to make sure they're educated about their IV site, and that they take their antibiotics, and that, you know, they give it on a consistent basis. So they just, you know, there's no playing around. We don't have time for any games. So, you know, we need to be diligent about what we're telling them, so that way they don't end up coming back to, you know, through the emergency room due to, you know, the infection now becoming systemic, and now they have a septic infection. All right.
Would they be doing dressing changes at home or going to the doctor to get that done?
Nope, they'll be taught dressing changes too. So it's not, you know, it's not just the, oh, this is so strange. It's not just the, you know, you talking about for the PICC line, or for the, dressing changes on the leg? Let me clarify first before I answer that question.
The PICC line.
PICC line, usually that dressing can hold. They may have to go to the physicians for it. I'm trying to remember when my girlfriend had hers. She went to the IND doctor, and they would do the dressing change. So after so many antibiotic infusions, that's what she would do. All right. Let's see if I had another question about osteomyelitis. This one is not necessarily about osteomyelitis, but it is about the trauma sprains. What is the mnemonic to treat it? When you have a sprained ankle or sprained knee?
Rice.
Okay, so we need to rest it, put ice on it, when they say compression, what's the compression? Is that, what kind of material are we talking about?
I would say maybe an ACE wrap.
It's an ACE bandage. And then we're going to elevate it for the first 24 to 48 hours. And that's to help to reduce swelling. We're not going to put heat on it. We do the heat after the 48 hours. And it may take several weeks for a sprain to heal. So it's not like you take a couple of ibuprofen and you're good to go. Okay. Should they be manipulating and doing, you know, full range of motion?
No.
Yeah, they shouldn't be doing that, because they're not resting it, right? So, and is there a way to speed up the healing?
Isn't a sprain like the tearing of the ligaments, and then the strain is the tearing of the muscle? Is that right?
So, it can stretch or tear the bands or the ligaments.
Okay, I guess that's what I meant.
Okay. So, yeah. So basically the ligaments that support the extremity or support the area like the ankle or the knee are stretched. And depending on how bad that is, you know, that person could be gimping for, you know, 2-3 weeks until that heals. All right, so let's see, there was one other thing about trauma sprains that I needed to just make sure it was cool. And all right, I think that was it on the trauma sprain. I'm just trying to cover all the immunity stuff while we're here, and then move on to another concept.
So on immunity, do we have to remember the CDC website, all the shots at what age?
The first year.
The first year?
Yep. And even if they don't ask a question on it this go round, you're still going to need it for your comprehensive and HESI. So they'll be like, man, I studied all those vaccines and they didn't ask now one question. And whatever they don't ask you now, they'll ask you later. So go ahead and commit it to memory so you can be done and over it. All right, so where does appendicitis, where does that normally start?
Umbilicus pain.
Okay, so they have pain around the umbilicus or the umbilicus. Okay, and then it radiates where?
To the McBurney.
So to the right lower quadrant.
Yeah.
Okay. And what signs and symptoms does the patient exhibit?
Abdominal cramps and pain.
Okay.
Nausea, vomiting.
Nausea, vomiting. All right. What's a hallmark sign of appendicitis?
The rebound pain.
The rebound tenderness. So, will that pain be intermittent? Would it be diffuse? Would it be persistent? What kind of pain would it be?
Persistent.
It'd be persistent. The rebound tenderness is not a reliable sign, as it's extremely painful to kiddos. And remember, kiddos, they really can't. When you ask them what hurts, they'll just roll over their entire stomach. So they don't necessarily pinpoint exactly where the pain is. They can't differentiate it that well. But your the sign that pretty much is the possibility that the patient may be having appendicitis would be persistent right lower quadrant pain. Okay. And they may or may not go to surgery. They'll treat it medically, give them antibiotics, and then continue to monitor their white count through their CBC and differential.
So I have a quick question about the appendicitis.
Okay.
So whenever we were talking about when the appendicitis or the appendix ruptures, in lecture you had said that generally the pain would stop.
Yes.
However, whenever I was going over the PowerPoints, one of them says that whenever it perfs, that there's increased generalized pain.
So that's when it ruptures. After it ruptures, there's nothing. When they're saying this generalized pain, because now what was in the appendix is where?
The abdomen.
It's in the abdominal cavity. So the pain that they had before is completely different. The reason why they're having the generalized pain is because now you have all that poo in the abdominal cavity, and now we have a peritonitis. Does that make sense?
Yes.
But it's two different types of pain. So that persistent pain that they had before is no longer there. Why? Because the pressure that was in the appendix is no longer what?
There.
No longer there. So once the appendix ruptures, now we have poo in the abdominal cavity, which means now we have a peritonitis that's brewing. That's a different kind of pain.
Gotcha.
Does that make more sense?
Absolutely. I just wanted a little bit of clarification for that.
No, you're fine. You're fine about that. But yes, that part is true, but we're talking two different pains for two different reasons. But that persistent gnawing pain that they normally have that starts from the belly button over to the right lower quadrant, and as it's under all that pressure from that infectious process, and if it's not treated, then yes, it's going to rupture. When it ruptures, basically you have whatever was in there, all the pus, everything that's in there, down to what started in the first place, which was a fecal lift, all that's now in the abdominal cavity and the abdomen saying, now wait, wait a minute, just slow down. And so now it starts to hurt because, we got something in here that doesn't belong. So, all right, UTIs. I think that's immunity too, right?
Yes.
Yes.
Okay. All right, so signs and symptoms, I think you guys are covered on that. Yes, maybe thinking about it.
Oh, yeah. Didn't we just talk about that a while ago? Or
Say that again.
didn't we talk about they get disoriented? They're not the older.
Right, that was elderly. We're just talking about UTIs in general.
Oh.
So I was just making sure that you guys understood that, hey, look, elderly people have a different presentation than the rest of the general population.
Right.
So what would be, we talked about the signs and symptoms: hematuria, urinary frequency, abdominal pain, spasms, fever, right?
Yep.
Okay. So we talked about different causes, catheterization, CAUTIs, the inappropriately placed or inappropriately inserted in the wrong hole and put into the urethra, or, wiping from back to front instead of from front to back. So we've covered all those issues. So what are some ways to prevent UTIs?
Increased hydration.
Increase hydration. Okay. So can I drink my Dr. Pepper?
No.
Oh,
Okay.
Yeah.
It won't help me. I can drink it, but it won't help me. But we want lots of water so that we can help flush out the bacteria, right?
Right.
Okay. What else can we take?
Proper hand hygiene.
Proper hand hygiene. I like that.
Some cranberry juice.
Cranberry juice.
Vitamin C.
Vitamin C. We need 1,000 milligrams of that. We need to take that. And what it does is it changes the bladder wall. It doesn't allow for the bacteria to stick on it. So it changes the pH in there. What else? Should they take a tub bath?
No.
Shower.
No, they should shower. Okay. They need to clean the perineum, right? From front to back. What about those nylon panties? Would that
They
be
should
appropriate?
be cotton.
So it should be cotton underwear. So those are all types of things to help prevent, and tight clothing. We don't want that either. You need to breathe, get some airflow. And you have tight clothes, nothing can breathe in that area. And bacteria likes things that are what? Warm and
moist.
Moist.
warm and moist.
So no skinny jeans.
I mean, I'm not saying no skinny jeans, but if they're skinny that, you can put a quarter in the back and read the date, then no.
Got to throw them away, Martin.
So no, we don't want to do that. All right. So let's see. What about, okay, so I think we're good on UTIs. I think we got that one covered. Let's see what else I want to talk about. Oh, I knew what the question was about appendicitis I wanted to ask. Okay, so outside of the persistent abdominal pain, what other series or symptoms would kind of lead you to believe that the patient may be having appendicitis?
Elevated white blood cell count.
Okay, so just on your assessment, not a diagnostic, just on your assessment. But you're right, Nico.
You said for appendicitis?
I went back to Appy because I knew there was one other question I wanted to ask you about that.
It would be like the rigidity, the muscle spasms, maybe tachycardia.
So
Guarding.
you want to look at the severity, right? Which would be that persistent pain. You would want to look at the location, because if it's in the right lower quadrant, then we would be looking at appendix. Unless it was a woman, you would be considering the ovary, right? Would that be a correct presumption, the right ovary?
Yes.
However, remember, we're looking at the pain, where it started, and then where did it move to. So we're looking at severity, we're looking at location, we're looking at pain movement, vomiting and diarrhea and those types of things, fever. That could be for a myriad of issues, not just necessarily appendicitis. Does that make sense?
Right.
So kind of that hallmark that it starts around the belly button, moves over to the right lower quadrant, that kind of lets us know, ooh, this sounds like appendicitis. Usually, if it's a woman and they won't have periumbilical pain, they would just basically have right lower quadrant pain if it's the ovary. Does that make sense? That
Yes.
coming across appropriately?
So I read that they would do a urinalysis to rule in a urinary infection.
Right, but what I'm saying on assessment, your assessment, before we do diagnostic studies. So when your patient comes in and they're thinking they may have appendicitis, you know, hey, my stomach hurt, the right lower quadrant, then as a nurse, you would come back with, what did the pain start in another location and move to another location? So, you know, tell me, where did the pain start? Did it go anywhere? That helps you kind of narrow down if it's actually appendicitis. But if are you talking about the right lower quadrant pain for a woman?
Yes. For that one, I read in the book, it said that sometimes they have to do a pregnancy test to rule out ectopic pregnancy.
That's right. Any woman of childbearing age, this doesn't matter if it's the right or left lower quadrant, any woman of childbearing age with lower abdominal pain is considered an ectopic pregnancy until proven otherwise. Really what they're ruling out is if she is pregnant, and then two, they're going to be looking at, okay, is this an ectopic pregnancy? So that's how they're going to function. Is this an ectopic that we need to be concerned about? So from that standpoint, that's what the book is saying. But what I'm saying, if a person comes in and they have this right lower quadrant, you would be thinking something ovarian or female reproductive system, correct? You wouldn't be thinking necessarily appendicitis unless you had someone saying they had pain around their belly button and then it moved over to the right lower quadrant. Does that make sense?
Yes.
That's what I'm saying. So yes, you're right with the right lower quadrant pain, that you should be thinking that it's gynecological in nature when it's a woman. That is true. Okay, so let's see what else. I think that was all, I believe. I'm just.
Can you please go over the treatment, the medication for that, for UTI?
What are you speaking about, babe?
Because I was doing the preview question, I came across this medication. I didn't write it down. The one that turned the
Is this for
urine.
something that's in immunity? Because that's where we're talking about the concept immunity. So that way we don't go all over the place. So I'm trying to cover the concepts or the exemplars in immunity first. Because we already have an acid-based question or section to follow up, because that was another question.
I'm talking about the medication for UTI.
Okay, what about it?
I came across this medication, the one that turned the urine orange, and I didn't see that in the list of medication in class. We didn't talk about that in class. So it's a lot of question about that on PrepU. I'm so confused.
Okay, what's the medication?
I didn't write it down. I didn't write it down. Sorry.
I mean, they could get a cephalosporin, they could get Bactrim, they can get Septra. I mean, there's several that can be used. Macrobid. So I'm trying to hone in on what you're.
Are you talking about like Peridium? Did you say that it changed the urine?
Right. So they have the antispasmodic to help with the spasms, but she said I thought she said antibiotic. Am I incorrect?
Yeah, she said the antibiotic, but she said something I thought that made the urine turn colors orange. That's why I thought Peridium, but
Well, that's not an antibiotic. That would be an antispasmodic.
Oh,
but I was just.
But the antibiotic, there's several that they can take. They could be on Cipro. They could be on Keflex, they could be on ceftriaxone or Rocephin, they could be on amoxicillin. It just depends on what the bacteria is. So did you find what you had a question about? When you find the question, then just bring it back up. Or not necessarily the question, but the medication, then we can
Okay.
move through it. But I'm we talked about the cranberry juice, we talked about antibiotics. I'm just trying to figure out what, we have the pyridium. So just trying to figure out what medication you were talking about on PrepU. It is literally pouring. It is raining cats and dogs. I am not lying out there.
What area are you living in?
North Richland Hills.
Oh, you're a ways from me.
Uh-huh. It's coming in from the west. So like Burleson, it's coming from that direction.
I think I found the name. The name is I have to spell it. I don't know how to say it. PHENA.
Hey, hang on. It's thundering and I can't hear you. So I'm like, hang on. All right, go ahead.
It's spelled PHENAZOPYRIDINE.
Okay, type it in the chat. I think that'll be the easiest thing to do. I heard CHE. Yeah, type it in the chat and I'll address it and then we can move on to the next piece. So that's the pyridium, but that's the actual name. The phenazopyridine, so that's what that is, phenazopyridine, which is basically for urinary pain relief. So it's the azo.
Also, inside the book, I read that penicillin is not commonly used because of its resistance to E. coli.
Okay, so let's. Are you still talking about UTI?
Yes, sorry.
Okay, but we didn't say penicillin. There's several medications, cephalosporins, Levaquin. There's different medications a patient may be prescribed. Besides, and the only penicillin I can remember is amoxicillin. I think there was a doxycycline, but that's not a penicillin though. But there's several different ones. Erythromycin, which is azithromycin, which is a Z-Pak. So there's Bactrim, there's Septra, there's a bunch. I think for what you just have to understand is that there's several different antibiotics that can be used. The patient will need to be on antibiotics. They will be, not can be, they will be on the phenazopyridine, the phenazopyridine, they'll be on that, which is the pyridium, and that we need to tell them that this is going to change their urine darker to an orange or a red color, but this is normal. Okay, so we can move on. All right, so let's look at tissue integrity. And then we'll go on to the acid base. All right, so with tissue integrity, and I'm going to combine a couple things with that. What types of patients would be at risk for developing an ulcer?
Elderly.
Okay.
Or like
Mobile.
paralyzed patients.
Immobilized patients, the elderly. Okay, what else?
Cancer patients that are immunocompromised
Okay.
with chemo or radiation.
What about people that are incontinent?
Yes.
Incontinent.
Your
Yes.
incontinent folks are at the greatest risk of developing a pressure ulcer because they're laying on something that already has toxins in it and it's sitting on the skin, right? So if you have a person that does develop an ulcer, what lab value do you want to get and why?
Albumin.
Their albumin.
You want to get an albumin, why?
Malnutrition.
It gives you the information about malnutrition. And so we want to, if we're talking about tissue repair, we want to make sure we know what's going on. Okay. How long, if you have a patient that, say, for instance, they have orders to ambulate to like the chair or something like that in their room, how long should they leave patients in chairs, or how long should we leave them in any one position in the bed?
No more than 2 hours.
No more than 2 hours. So every 2 hours, the patient needs to be either rotated or they need to be moved to a different location, but they can't still stay on the buttocks area. So we need to move them around a little bit. Okay. So if you did have somebody with an ulcer and it was draining, then what lab value would you consider at that time?
A wound culture.
A wound culture. Okay. Name me some patients that are prone to developing ulcers.
Diabetics.
Diabetics, for sure.
The elderly, those that are immobile.
Okay. And not just elderly, just anybody that's immobile. You don't have to be 80 years old to get a decubitus ulcer. You could be 22 years old and get one. So if you're not moving or you have diabetes, then this can happen. What else?
Patient with poor perfusion.
I'm sorry?
Poor perfusion. Like they have a DVT.
But that'd be an immobile person. So immobility for whatever reason, whether it's quadriplegia, paraplegia, people that don't move. What about your
People with cast.
a cast? What about your folks that have peripheral vascular disease?
Yes.
Would they be at risk for an ulcer?
Yes.
Yes, they would, because they have decreased circulation. So that's why they would be at risk. All right, so if you have a patient that, that have mobility issues and say they're diabetic and they have neuropathy, how do you prevent them from being injured? So this is when they get home.
They need to always wear footwear.
You need to teach them to be checking their feet every day since they can't feel it.
Okay, so inspect your feet daily. Okay. What if the
Where-
person can't bend? I mean, it's not that they can't bend, but say they're obese, then what's your second option?
Put a mirror in the floor and hold your foot above it.
Okay, so somehow, or, get an extender and put the mirror at the end of it. So there's, but somehow they need to inspect their feet or get some kind of a hand mirror of some sort so they can see all areas of the foot. All right, so proper shoes, proper slippers that have the no slip bottoms, right? Anything else that you think that they should do at home? What about their skin?
Moisturize the skin, put some barrier cream on.
Okay, definitely, put on some lotion to prevent dryness. Should they put it in between the toes?
No.
No, because that'll be a breeding source for bacteria. Okay. What about if they have a callus, should they just, cut it off?
No.
Okay, so basically once they have diabetes or anything like that, they should go to a podiatrist to get their nails and things done. Will the neuropathy get better or worse?
Worse.
It can get worse. So, you want to talk about, educate them on that too. Should they apply heat?
No.
No. No heat. Why?
Well, they won't be able to feel the burns.
That is true. They will not be able to feel the burn. So we don't want to be putting heat on. Should they walk barefoot?
No.
Okay, I can tell you that must be a Southern thing, because I see more barefooted folk. I was like, where are your shoes?
That's me.
Like, and not just necessarily Texas. I mean, it must be, because even in the South, where my parents are from, it's like, where are your shoes?
Country.
Up north, everybody has shoes on. It's just like, no, very few people are walking around barefoot. Other things you want to, kind of pay attention to, or that may, other treatments or things, is if they notice any drainage or, soreness or anything like that, they need to go to the PCP. So, those are things that we need to kind of incorporate.
Would their diet be high calorie, high protein?
They would do, yeah, but you remember they can't do too many calories because of definitely protein, not necessarily high calorie.
Okay.
Because they're diabetic. So, trying to see if there was anything else. Okay, so let's do some acidosis stuff. There was a concern about hypoxemia.
Yeah, that was me. I couldn't understand, because when I think of hypoxemia, I'm thinking CO2 retainer, and then same kind of
Okay.
with AF in a sense.
So
because
if they're CO2 retainer and they have hypoxemia, what's their breathing pattern?
they're grasping.
I mean, just think about it.
Oh, that's true.
So in that beginning stage, what's going on?
I'm sorry, what was your question?
When someone has a buildup of CO, if they're a CO2 retainer, so that means we're not getting enough oxygen through, what signs and symptoms does that CO2 retainer person has? What is the biggest sign and symptom related to that?
Cyanosis?
before cyanosis, because it could be cyanosis or no cyanosis, depending on if it's emphysema or chronic bronchitis, right?
They're going to have like tachypnea.
They're going to be breathing fast. So if you're breathing fast, what are you doing?
You're hyperventilating.
Thank you.
Okay. Okay.
Am I right?
Yes, but when you're like in a respiratory failure,
You're breathing fast then. When they get to the acidosis part, this is going to be later on. It's not going to be immediate. It's going to be when the body tires out, when they become fatigued, when those respiratory muscles cannot, they're just too tired to go any further. Then that we're going to see a shift.
okay.
Okay. So which system is the fastest?
Which system is
And
the
since we're talking about acid base, so we talked about the buffer system, the renal system, the respiratory system, for compensation.
Respiratory is faster.
Respiratory is faster. Is it temporary or is it long lasting?
Temporary.
It's temporary. So the respiratory system responds rapidly to the imbalance, but the effects are easily short-lived. Okay. What about the renal system?
It takes like 48 to 72 hours.
So it's slower,
But it's lasts longer.
but it lasts longer. Okay. So although respiratory is quick, it tires out quick. And renal starts slower, but it lasts longer. Okay. And, although the renal system is much more effective and powerful. Okay.
Mhm.
All right. So if you have a patient that has anxiety that has just come out from surgery and they're complaining of incisional pain and they're breathing at, 36 and their blood gas says they have respiratory alkalosis, what should you do?
We need to treat their pain and anxiety so that they'll calm down.
So we should treat the pain for sure, because that's the reason why they're breathing fast, right?
Mm-hmm.
And if you're breathing fast, then you're blowing off more CO2. So the increased respiratory rate is because they're in pain and they have anxiety. So if we treat that, then we should be A-okay. All right. So if you have a patient that is in diabetic ketoacidosis, throw out some numbers of what you would expect their ABG to be.
Their pH would be like 7
So,
point.
well, first and foremost, if they have diabetic ketoacidosis, what acid-base imbalance would they be? What would be your
Metabolic.
Metabolic.
Okay, metabolic acidosis. So we all agree on that. Okay, so in metabolic acidosis, give me an example with a pH, a PCO2, and a bicarb. What would you anticipate to see based on the Rome mnemonic?
So the pH would be like 7.2. The PaCO2 would be like 37. And the HCO3 would be like 20.
Okay. So your pH and your bicarb would both be low, right?
Yes.
Okay. Excellent job. Excellent job. What if it was respiratory acidosis? So based on the ROME, give me some numbers for pH, PCO2, and bicarb.
The pH would be like 7.2, PaCO2 50, and then the bicarb would be at a normal, say 22.
Okay. Like it. So, not only do you have to know if it's respiratory alkalosis or acidosis or metabolic acidosis, alkalosis, you got to know what the numbers would also look like. So this is why doesn't make any sense. Oh, well, it's this, but then you get to the numbers, you're like, well, we didn't talk about that, but you got to be able to put those kind of pieces together. All right, so what if you have a patient has an NG tube and it's draining a bunch of liquid, a bunch of, GI liquid.
So they probably go into metabolic alkalosis.
So yeah, we want to monitor them for metabolic alkalosis because that, our GI system is on that metabolic side, right? The drainage has acids in it.
Yes.
So that we would be getting rid of most of that, putting us at risk of alkalosis due to the gastric acid loss. Okay. Patient with Kuhl's-Moss respiration.
We like respiratory alkalosis.
Is she correct? Is she correct?
Yes.
Kuhl's-Moss respirations. When do you get Kuhl's-Moss respiration?
You get it during DKA.
So is DKA respiratory acidosis?
Well, so during lecture you said, so if they were in DKA, technically they'd be a metabolic acidosis. But
Right, but you said respiratory.
Well, yes, but because they'd be in DKA, that then they would start doing the Kussmaul breathing, which would lead to respiratory alkalosis.
I don't think I said that, and if I did, then that's not correct. So anytime you see DKA is metabolic acidosis, not respiratory. If they have Kuhl's-Moss respiration, that is metabolic acidosis as well because it's part of what? DKA. I think what you might be getting it confused with is COPD because that would be respiratory acidosis. Alkalosis.
So you're saying COPD is respiratory alkalosis and not acidosis?
Acidosis. What did I say?
You said it was alkalosis.
Okay, so let's back up. For the DKA respiratory, that's not respiratory, that's metabolic. So anything that's diabetic keto driven is on the metabolic side. It is not respiratory. So DKA, Kuhl's-Moss respirations is metabolic acidosis. So let's start with that part. Now, when you're looking at the metabolic side, I think you're talking about pursed lip breathing because that's what we were talking about at that time was pursed lip breathing, right? Because pursed lip breathing would be in what condition?
Emphysema.
That would be an emphysema, which is COPD. So that's completely different than Kuhl's-Moss respirations. So one's pursed lip breathing, the other one is Kuhl's-Moss respiration. So that would be two different components.
Ms. Hudson, is it a possibility for them to say, go into respiratory acidosis and then have more, how do I explain it? Can they go into both or
see what happens with
one or the other or?
COPD, don't they retain CO2?
Yes.
Yes.
Okay, so if you're retaining CO2, how is that impacting your body?
It's not getting enough oxygen.
Okay, so you have more toxins, more acids on board.
Right.
That's why it's respiratory acidosis. So don't confuse pursed lip breathing and Kuhl's-Moss respirations. Those are two different things.
No, that wasn't my question. My question is.
No, that was the first question that came up. right? Am I correct in that? Was that not the first question that came up?
No, not the one. I was just trying to explain my question. I didn't ask that. It might have been something that Courtney may have asked. I'm not sure.
Right, that's what I'm saying.
Oh, okay.
So I want to make sure before we move on to your question that we have that question cleared.
Yep, I got it.
Oh, okay. Because COPD is respiratory acidosis. So that would be, if it was emphysema, pursed lip breathing, respiratory acidosis. If we have Kussmaul's respiration, then that's metabolic. All right, now go ahead. Now what's your next piece?
My question is, and forgive me if I don't make myself completely clear, but can someone go into one or the other or both at the same, both at the same time or at different points? Like,
usually there's a transition, but from the respiratory side.
yeah, could they start out in acidosis and end up alkalotic? Does that make sense, or am I not making
Well,
sense?
if they're alkalotic, that would mean someone would have had to have provided the oxygen for them to flip them on the other side. Does that make sense?
Yes.
But so it is possible to flip them when you're trying to intervene.
More than likely, you won't get that far, but that's what respiratory is there to monitor, so that way they don't go to the other side. Does that make sense?
Mm-hmm.
So what I just want you guys to do is to keep ABGs really simple. Don't what if it. Just answer the question as it's being given. Don't think of it, well, maybe they can go into so-and-so and such and such. Well, I don't know how long they've been this way, so they could now turn into so-and-so and such and such. Don't do that. Because then it will be things that that you will talk yourself out the answer for. So whatever the question is, we know that GI losses, we're going to end up losing acids because it's going out, right?
Mm-hmm.
So that's the reason why that individual would have a metabolic process. Would that be alkalosis or acidosis? The one with the NG tube.
It would be
alkalosis.
It'll be alkalosis that we're going to monitor them for. Okay. Because the acids are going, they're not staying, they're leaving. So if they're leaving, then that means we're more base than acids. Does that make sense?
yes.
Okay. If you have somebody that has COPD, we already know that's respiratory acidosis because of the reduced exchange between O2 and CO2 being maintained or it's staying in the body system, which is increasing the hydrogen ions that can circulate through the body. So we got that part. All right, now my next question for you is a person that has bulimia. What acid base, what imbalances would they have from a fluid and electrolytes and an acid base? Let me see if you can put these two together.
So like being in metabolic acidosis, is that what you're asking?
So I want to know what would be their acid base imbalance. That's the first question. So would it be respiratory acidosis alkalosis? Would it be metabolic acidosis alkalosis? That's my first question. Then my second question, hang on. My second question is, knowing that they have bulimia, what electrolyte imbalance would they have? So let's answer the first question.
Metabolic alkalosis.
So bulimia is metabolic alkalosis, and that's because the hydrogen ions are going to be lost from the frequent vomiting, right?
Mm-hmm.
Yes.
Okay. Now, what electrolyte? So if we're losing acids, what electrolyte are we going to lose also?
Like potassium?
Potassium. So they would have hypokalemia.
which is metabolic alkalosis.
Right. Well, hypokalemia is not, it's related to the potassium loss due to the vomiting. The vomiting, since we're getting rid of acids, means we're going to have more we're going to have more base in the body system. Does that make sense?
Yes.
Okay. I hear some gasping.
No, I think that's my paper.
Huh?
I think that might have been some scrambling with paper.
Oh, I thought heard someone go.
Oh, they might have. I didn't hear it.
It could have been me. I'm sick, so I'm having a hard time breathing.
Uh-oh, poor baby. All right. So does that help you with the acidosis, alkalosis, respiratory metabolic? So pursed lip breathing, COPD, respiratory acidosis. Hyperventilation, respiratory alkalosis, because we're blowing off the CO2. We're getting rid of the base. Metabolic acidosis, that will be Kussmaul's respiration and DKA. NG tubes, draining stuff, people with bulimia, metabolic alkalosis. Okay?
So just keep it simple.
Yes, keep it simple. Trust me, do not go down the rabbit hole. Don't do it, Miss Seeley. Don't do it. So, yeah, don't start what ifing it. Don't do any of that. This is supposed to be basic. It's supposed to be simple. It's not supposed to be complicated. Okay. So, when your patient have dressing changes, should you medicate them before you do the dressing change?
Yes.
Absolutely. Should you medicate them right before you rip the dressing off?
No, like an hour before if it's PO.
I had never been so appalled. And the nurse was sitting there waiting for the surgeon to come up to give this man his medication before they did this dressing change. And as soon as the doctor hit the floor, she did it right then and there. But it didn't have time to work. And he was ripping off that dressing. I was like, oh my gosh. Like, this is crazy. All right, so let's address COPD and asthma and all of that. And then we'll finish up with the human development, because I think we've already covered tissue integrity. So let's go to that piece. All right. Oh, I knew there was something I missed on immunity. If a kiddo, let me do immunity before I move on. If a kiddo has an ear infection and they've been taking antibiotics already, they finished it, and they took everything like they were supposed to, what information or what sign or symptom would you monitor for after the medication's been completed that would let you know, or that would be of concern? Let me just say it like that.
Hearing loss?
Okay. But hearing loss happens much after so many.
Oh.
Ear pulling.
Okay. So they can pull the ear, but
Fever?
fever. That would be your biggest concern if they develop a fever. So if they develop a fever after they've completed the course, then that illness is severe.
So like a low grade or a 104? Or just
Well, for a kiddo, so say it was 101.3, or if it was over 101. So not even if it was a 0.3. So anything over 101, because low grade would be like 100 point, like 100 degrees, right?
Yeah.
So if we're over 100 degrees, then we need to be looking at something else. They may have had the ear infection, but they may have something else going on. Does that make sense?
Yes.
Because afterwards you should be afebrile. But if all of a sudden the kiddo spikes a fever, then okay, we need to do something different. Now for an infant, the fever shouldn't be more than 100.4. So usually if a kiddo that's an infant have 100.4 fever, then that is going to be significant. They will do a septic workup for that individual. Now, if they have over 100.4 fever and they've had an upper respiratory infection and they're pulling the ear, then what are we looking at then?
Infection.
So we have a kiddo with a fever over 100.4.
Mhm.
They've had a upper respiratory infection and they're pulling their ear.
Ear infection.
That's an ear infection. Okay, somebody may have said it, but it didn't come across that way. All right, so did you say that, Martin, and I just totally didn't hear it?
No, because I thought we were talking about ear infection, so I didn't. So I didn't say ear infection.
Oh, okay.
I thought that was it for me. I thought that was a given.
Oh, okay. All right. So what type of assessments would you do? Or let's talk about assessments. Let's talk about diagnostics. Let's talk about patient education. So from all of those perspectives, where not necessarily where would you start, but what types of things would you expect to happen on assessment for a baby that's febrile and that we suspect has an ear infection?
They would have to
check their
look
ears.
in the ear.
All right, so we're gonna check it. We're gonna look in the ear. What else?
There's
The nose, auscultate breath sounds, right? We'll make sure they don't have pneumonia or anything else. Skin color, temperature, condition, cap
Would their lymph nodes
refill.
be enlarged?
Say that again.
Would their lymph nodes be enlarged?
They can be, but I wouldn't be, for a baby, I wouldn't be worried about that right now.
Mm.
You're like, huh. All right, so, but we definitely gonna look in the ear. We're gonna, we already know it. We got a temperature. We're gonna auscultate breath sounds. We're gonna look at skin color, temperature, condition. We're gonna do a cap refill. We're gonna make sure you have like mottled skin or something like that. Okay, so we would anticipate that the physician's gonna order what?
Antibiotic teardrops.
Antibiotics and pain medicine. So like some amoxicillin or something like that. Okay. What will
Some
help?
ear.
They're going to probably give some Tylenol, ibuprofen for the fever, because the
Wouldn't
antibiotic
they
is not going to
medicated or to
most of the time they don't do medicated ear drops. They just do antibiotics if it's bacterial, right? Now, what about things at home that could be potential issues as to why the patient developed an ear infection in the first place?
allergies?
Smoking.
So,
Smoking.
secondhand smoke. Those are things we want to make sure we keep the baby away from. When should they follow up with their PCP?
2 weeks.
So after they finish the med?
Yeah, I was gonna say after antibiotics were finished.
Yeah, so after they complete the medication, they should go back. So, and they're not going to be on the medication for a year, but it may be 10 days, it may be 2 weeks, depending on, how they prescribed it. But once the antibiotic is done.
I think the storm has got to me now.
Yeah, it's kind of quiet over here. I mean, my TV's on, but it's on mute, and I saw the emergency weather alert coming through, but then it never popped through. I'm like, okay, well, then I heard the rumble. I said, all right, here we go.
I live by a green belt, so I'm hearing the trees just going.
Yeah, it was pouring. It was pouring cats and dogs out here. Okay, so there was one other thing I wanted to talk about. Oh, okay. All right. I know we veered off. Okay, I'm gonna go back to our COPD and asthma people. Why do patients have why do both COPD and asthma patients have abnormal breath sounds when you're auscultating?
Because the structure of their lungs are jacked up.
What do you mean by jacked up?
The alveoli are flattened.
Is it flattened? That would be atelectasis, right?
Yeah.
Because that would be collapse of the alveoli.
They've lost their elasticity.
Okay. So if I have asthma, which I don't, and I don't want to put that on myself, if a patient or a person has asthma, what's actually happening in the bronchial tree?
Oh.
There's a narrowing.
The airway's narrowing. So that's the reason why they have the abnormal breath sounds. Because it's narrow and then it's filling with what?
Fluid.
With mucus, not necessarily fluid, but with mucus. Okay. If you have a combo medication like Advair, what two drugs are in Advair? That was part of that puzzle.
A bronchodilator and oh dear blank.
Help her out.
Would it be a bronchodilator and a steroid?
Okay. And so the bronchodilator dilates the bronchial tract. The steroid's going to do what?
Strengthen it.
Decrease inflammation.
Decrease inflammation. Okay, so give me the name of the two medications that it's in Advair. You're probably trying to find that puzzle. Where's that dang on puzzle?
See.
Is it albuterol and the ipratropium?
No, that would be an A&A. That would be albuterol and Atrovent, or the Duoneb. So that's not. We just said it was the anti-inflammatory, right? The corticosteroid, and it was a bronchodilator. So those two are not. One of those is not a corticosteroid. The A&A. They're actually both bronchodilators. So that's why those are the Duoneb. But I want to know the name of the two drugs that's in Advair.
Fluticasone, is that right?
Fluticasone, and what else?
Salmeterol.
Salmeterol. So that's what makes up Advair. But one drug is going to decrease the inflammation. The other drug is going to be a bronchodilator. It doesn't, eliminate, acute asthma quicker or anything like that. They just have to work together. Okay. Then they're both given. Go ahead.
That's with asthma, not COPD. Is that what we're talking about? Asthma?
I'm just talking, if you have a person with chronic bronchitis and they are on Advair.
Oh, okay.
So that's the name of the drug, Advair. If they're on it, I wanted to know what two drugs were in it, what's their mechanism of action. So, you know, some people have used it in asthma, but it usually in asthma, they don't get that drug. They get a multi-dose inhaler like albuterol. So they're not going to give this combo med because that's more long-term, right? It's according to the article that you guys read. And maybe you didn't read it. But if you read it, the evidence-based approach, you would find you would find it on page 52 of the article. But it is a long-acting beta agonist. So if it's long-acting, it's not designed for the short term. Does that make sense?
Mm-hmm.
So if you're having an acute reaction or an acute exacerbation of your COPD, then you need a short-acting beta agonist to treat that initially. So what Nico was saying was the albuterol and the ipratropium, that's your duo neb, but that's to treat something very quickly. And then they move on to, let's help to prevent it from happening. So let's give the person some coverage over a period of time, but that would not be used in the acute phase. So if your patient was admitted to the hospital for abdominal pain, what type of assessment and questions would you ask?
When's the last time they had a bowel movement?
Okay. So just speak on it from a body system standpoint, not necessarily the specific question, but what type of question would you ask?
Where is the pain located?
Okay, so basically what you're saying is you would ask questions related to the abdominal cavity.
Yes.
Okay. And then you would assess the abdominal region. So palpate the belly, auscultate for bowel sounds. So if the patient was complaining of chest pain, how would you do your initial assessment? And that would be in specific questions. What would the questions be geared towards?
Trying to figure out if it's true chest pain or like reflux or anxiety.
Okay.
Would you have them describe the pain?
Uh-huh.
Is it like a radiating pain?
Okay. Yep, those are all good. Those are all good. So whatever the area for where the patient is complaining, so if it's leg pain or musculoskeletal pain, then you're going to do a musculoskeletal assessment, and then you're going to ask questions specifically, you know, about that region, you know, CMS, neurovascular checks. Can you feel me touching you? Can you wiggle your toes? It'll be things like that. So that your specific questions would be about, you know, why the person is having musculoskeletal pain, or if they were having cardiac issues, and you would ask specific questions related to the cardiac issue, but you would do a cardiac assessment. Does that make sense?
Yes.
Okay. So wherever the affected area is, then that's where you're going to be asking your questions around and doing your assessment for. So if it's respiratory, then you're going to do a respiratory assessment, then you're going to ask questions related to whatever respiratory issue they may be having.
So if I come in with abdominal pain, don't be asking me about how my ears are.
Exactly. Exactly. So what is the most definitive way to check for a NG tube?
X-ray.
An x-ray.
An x-ray. And why do we put in NG tubes?
Deflate the stomach.
Okay. All right. And so why do we check for placement? What's our goal? And why do we check for placement and residual?
To make sure it's in the right place.
That too, but what else?
Make sure we didn't
We
perforate.
check for placement because we are trying to make sure that whatever we are giving the patient is not going inside the lungs.
So we also want to prevent aspiration. So with that's why we want to make sure the tube is in the right place and with that it's not going in the lungs, and we check residual to make sure that, you know, we're not having any issues. Okay.
Mm-hmm.
So if your patient does have a feeding tube and you notice a new onset of crackles, what do you do?
Call the doctor.
Discontinue the feed.
Stop the feedings.
Okay. And then you're going to, what are you suspecting is wrong with the patient?
Aspiration.
That
They
the
have an aspiration, and then you're going to call the physician to say, hey, blah, 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 these are the lung sounds. You're going to give them an S bar. Okay. If you have a patient on oxygen and they start to become confused, what should you check
ABGs.
before that?
O2.
O2 what?
Saturation.
Okay, check a pulse ox. You want to make sure they're not having any type of cerebral hypoxia. All right, so the one thing I did not cover was a TE fistula. So what is a tracheal esophageal fistula?
Like a pocket, almost.
Okay, and there's different types, right?
Yes.
Yes, there's like 4 or 5 different.
Okay. So what are the 3 things you're looking for?
Choking, coughing, cyanosis.
There you go, choking, coughing, and cyanosis. So those are the 3 things that you would be looking for with those individuals. So, and when would you normally see these signs?
Maybe
How would you know that they're having an issue with choking?
when they're eating.
Okay. So what else besides eating?
Drinking.
Besides anything that has to do with feeds outside of that?
Breathing.
What was the question?
How would you know your patient is having a problem, you know, with choking? But you primarily answered the feeding part. So like eating and drinking. So I said outside of that. So how would you know that they're choking?
If they put their hands around their,
This is
like,
but wait a minute. TEF happens in kiddos. So this would be in a newborn. So
oh, okay.
the newborn won't be able to get their hand up there.
Right.
Really gasping for air.
Okay, gasping for air. But if they're gasping for air and they're choking, what else would be happening in their mouth?
Is it the frothy bubbles?
Frothy bubbles, I love it. The frothy saliva. She goes with the frothy bubbles. I love it. So yes, we want to be looking for frothy saliva, but remember if they're choking, remember we said cyanosis, choking, and what else?
Coughing.
Coughing, then that means they can't manage those secretions. So they can't swallow them because it's so much in the mouth. So yes, we want to make sure that, you know, we're looking for that. That's kind of another sign that, you know, hey, this is going to be a choking problem. Let's see. All right, so I think I told you guys to look at the peak flow meter and the number or the percentages or whatever, right?
Yeah.
Did you do it?
Yep.
Okay. So give me some feedback on the ranges.
So green is like 80 to 100%.
Okay, so what does that translate to? If the green is 100%, I want to know what is the milliliters.
Oh.
Somebody says, "Oh God." So what is the liters per minute? Not milliliters. What is the liters per minute if it's in the yellow?
How about the
If it's
color
yellow,
I'm looking for it.
concentrations between the oxygen
yellow,
and the air?
Say
is it
that
like,
again. There's 3 people talking, so I'm not sure who I should be listening to right now.
I thought the colors were just the concentration between oxygen and air.
Okay, so the colors do give that, but sometimes they give it in liters per minute. Uh-huh.
oh, the 320 is good, right?
What does 320 mean?
320 liters per minute for inhalation.
So that means, are you saying that's green? So go to your Reese book, and so that way you won't be wagging it, which is wild blank guessing. And I think it's like page 1500 or something like that. But you're right, green is 80 to 100%, yellow is 50 to 80%, and red is less than 50. So the question of the day is, how does that translate over into liters per minute? And that's the question. Because I did say that the peak flow meter, some of them don't do the percentage, they actually do a number value. So besides knowing the stop sign, you actually have to know both. So that way you don't, if someone doesn't have just the red, yellow, and green percentage, you won't get caught off guard.
That answer anyway.
Somebody smoke detector bumping.
And you said it's in the Reese book, like the maternity book?
Yep, because that's the pediatric book. Like 1500 and something. Like 1506 or 7 or something like that. I just remember it being in the low 1500s.
Well, I see something about peak flow rate, but it says green is good control, greater than 80% personal best. Yellow is caution, red is medical alert, but not anything about a.
Yeah, I'm not seeing any liters either, just the percentages.
Okay. All right, so here we go. If it is, let me make sure I say this right. If your peak flow meter is in the 50 to 80% range, that's the yellow. And that's, you know, around the 180 mark. So that would, yeah, it's around the 180 mark. So it should give you additional numbers. Let me make sure I say it correctly.
I was gonna say, I mean, I found the chart on 1506, but
You found it on 1506? Okay, go ahead.
Well, about the peak flow meter, it only has the percentages. I haven't found anything with the actual liters per minute.
Mm-hmm. Okay, let me go to Reese real quick, so that way I won't be talking out the side of my neck. I mean, I still could talk out the side of my neck, but we're gonna try to fix it real quick. I'm just gonna go to the ebook. I'll find it. We're gonna keep moving. I'll find the numbers so that way you'll have the numbers. So that way you don't, no matter which way they ask it, you know, you don't be like, well, we didn't cover that. So I just want to make sure that.
So does that mean that there's a question about this on the test?
I don't know for sure, but peak flow meters is a good measurement of, you know, how restrictive a person's airway is. So besides the percentage, and if you look, if you Google, you know, peak flow meters, then some of it is just not only the red, yellow, green, it has a number value associated with it. So that's why I'm saying you don't want to just know the red, yellow, green. You want to know, what does the yellow mean? What number would that be in liters per minute compared to, if it was red, then what would that be in liters per minute? Does that make sense? Mm-hmm. So since we are talking about gas exchange, I could see a peak flow question being asked just because of the fact we're doing gas exchange. And I'm trying to remember if I saw that in the article, or if I read it in the article, the COPD article. So that's, before I go to Reese, that's where I'm looking right now. I'm just kind of scanning through. But I do remember somehow coming across the whole peak flow meter besides the red, yellow, and green, and actually, you know, what the numbers were, what did the yellow mean, what did the red mean. So I'm just trying to get back to that. But the higher the number, the less restriction the individual has. So, and I believe it went up to, I believe it went up to 400. So if your personal best is, and it's based off of the person's personal best, if it's like, you know, 300, say for instance, their personal best is 300, then anything less than anything greater than 220 would be A-okay. Does that make sense? So if the best that my best peak personal peak flow meter is, or my peak flow reading is to 275. We'll just use that as a number. Then anything over 220 is good. Then I would be considered in the green.
So this 80, okay, so the 80 to 100%, say on the green flow meter, is 80 to 100% of whatever that personal best is. So like you said, if the personal best is
275, then you multiply that times 0.8, and that would be 220.
Right.
Okay. So if the person's personal best was 275 and they were, then you would look at the range of 50 to 80. Does that make sense? Then that would be their yellow zone. If their personal best was 275 and that range would be less than 50, then it'd be less than whatever the number is, 50% of 275. Does that make sense?
Mm-hmm.
I think I had a prep you question like this.
So say for instance, the person's personal best was 400. Give me the green, the yellow, and the red. When would I be, how would I figure out what their liters per minute is? So I'd take that 400 and I would multiply it times 0.8, right?
That was 320.
So that'd be 3. So anything above 320, we are in the green. Does that make sense?
Mm-hmm.
So now I'm going to take the 400 and I'm going to take it times 0.5. And that's, so between 200 and 320, I'm in the what?
Yellow.
I'm in the yellow. And anything less than 220 is what?
Red.
There you go.
Now, is the yellow 50 to 80 or 60 to 80? I have 60 to 80 written down.
50 to 80. And your danger zone is less than 50, less than 50.
You would have to know the patient's personal best.
Right.
Would that be part of the assessment?
It would be provided. So somewhere you would ask, what's your personal best on the peak flow meter? And they would have to know it in order to understand what zone they were in. Does that make sense?
Yeah.
So whoever their pulmonologist is or PCP would have already had that discussion with the patient to say your personal best on your peak flow meter was 325. So then everything will be based on that 325. They're 50 to 80 range and then less than 50.
And just for my knowledge, how long is this number good for, your personal best?
Until you achieve a different personal best.
Oh, okay.
So if your personal best is 270, then you go with 270. If your personal best is 318, then you go with 318. If your personal best is 410, then it's 410. But whatever it is, then you start going from that place backward, not backwards, but you multiply it times 0.5 and 0.8 to get your range. Does that make sense?
Yes.
Okay. All right. I think we're, somebody's doggy is not good having
That's
fun.
my 110-pound lap. Sorry, she's downstairs.
Mine is asleep. He hasn't made a sound. I think he's mad with me. All right, so we have about 6 minutes. Is there any question I didn't answer? I think we got the acid base covered. We got the peridium covered. We talked about the immunity. We've covered PD stuff. So things, I'm going to go back to the beginning, I guess, with the human body questions. So, I keep saying human body, but I mean human development. Where I want to go with this. No, not that. Other, do you guys remember the long word for croup?
Bronchiolitis. Ow. It's the RSV.
Nope, that's respiratory syncytial, but that's not croup.
Oh, I thought it was the.
So the long word for, how do you know if someone has croup? How do you know if a baby has croup? Or a kiddo?
Is that whooping cough?
No, that's not whooping cough. That's pertussis.
Laryngotracheal bronchitis.
That's it. Laryngotracheal bronchitis. That means it's inflammation of the larynx, the trachea, and the bronchial tract. So that's what laryngotracheal bronchitis is, croup. And croup, what's the hallmark sign for croup?
The cough.
What kind
Hacking
of cough?
hacking.
It's a seal-barky cough. So what is the best way to treat that? Because it's the epiglottis, it's the area around the epiglottis that's swollen. So on the periphery of the epiglottis. So what's the best way to treat that if you have a kiddo? And this will be the time that kiddos will become sick with croup. It will be between fall and spring. So how do we treat it? What are some things we can, tell the parents if this was to happen again? Is this bacterial or viral, by the way?
Bacterial?
So would we tell them to use like an anti-inflammatory medication?
No. So let's clear up whether it's bacterial or viral. It is viral. So croup is viral, right? Although it has the itis, this is a viral itis. So if it's viral, then antibiotics probably won't work, right?
Correct.
Okay. So what happens if kiddos get this condition during the winter months? So usually, does it get better? And if so, when does it get better?
Would it get better after the winter?
No, I'm talking about when the kiddo has a flare up. So the kiddo has a flare up and they're in the house and then they take them outside. Normally in the, during the late fall, winter, what's the temperature outside?
In the 30s.
So it's cool. So what helps to fix croup is cool mist or humidified air. So what parents can do at home is turn the shower on in the bathroom, let it get really steamy in there, shut the door, then turn the shower off and bring the kid into the bathroom and let him or her inhale. And actually boys are more prone to croup. Let him or her inhale that steamy mist, that humidified air. So that's how you treat croup. So that would be in that human development.
Is there any difference or benefit between cool mist versus warm humidified mist?
No, because actually the cool air, there's humidity in it. We just don't know how much humidity is out there. Does that make sense? And what it does, it helps to minimize the inflammation on the periphery of the epiglottis. So that means on the side. I mean, the epiglottis. Now, croup and epiglottitis, what's the difference between the two?
Epiglottitis.
Epiglottitis. So this is epiglottitis would be inflammation of the epiglottis. Where's your epiglottis?
Is that the hangy down thing?
No, that's the uvula.
Oh yeah, the flap over your trachea.
Yes, that is the flap over the trachea, where it decides whether you're gonna, it's gonna cover it and cover the trachea, and the food's gonna go down the esophagus. That's that piece.
Yeah.
Okay, so if you have somebody with epiglottitis, that is inflammation of the epiglottis. This will be a bacterial infection. This kiddo will be super sick. So, they're going to have a severe, the hallmark sign to this condition is that the patient cannot manage their secretion. So they're going to be drooling. So drool is going to be on both sides of their mouths because they're not going to be able to swallow. And we're not going to do anything to excite them or anything like that because the swelling to the epiglottis is in the front part. It's anterior swelling. Is that good or bad from peripheral swelling?
It's worse.
It's worse. So if you upset the kiddo, then what you run the risk of doing is having that epiglottis shut, spasm, and then close. Would that be good?
No.
Because then the patient can't breathe and they will probably die. So that person you'll keep calm. They'll usually have like a low-grade fever. Oh, no, I'm sorry, not a low-grade fever, a high fever, sore throat, stridor because of the airway closure, the swelling of the epiglottis. But they cannot manage their secretion, so they're going to have drool and jaw jutting. And basically, jaw jutting means they're just going to stick out the lower chin to help facilitate the drool. So any invasive procedure will be on hold. We do that person needs a definitive airway, which is like an ET tube, to help keep the airway open.
So with all those secretions, would we want to section with a yonker
Nope.
to help, or would that stimulate more?
Yep. So no yonker. You would just basically take a towel, tie it around, and let them drool on it. Don't separate the kiddo from the mother because that's now anxiety, and anxiety will cause that epiglottis to spasm and close. Make sense?
Yep.
So if you have a kiddo that is, when they were born, their birth weight was, we'll say 9 pounds. And so they're doing a 1-year checkup. And the kiddo weighs 15 pounds. Is this normal?
No.
Is that kiddo above or below
Below.
their expected weight for their age?
Below.
They would be below. Because they should weigh more than 15 pounds, right?
Just to double
when?
doubling their first year.
Okay. So I think this was Courtney that was asking that question. So it's things like that you have to know what to expect with kiddos and adults, and can they assess their pain, or what would be barriers to them assessing their pain. Same thing for adults. What do you tell a kiddo about surgery at a certain age? How do they understand it compared to that of an adult? Does that make sense?
Mm-hmm.
Yes.
Okay. So,
basically know your audience.
Say that again.
So basically know your audience.
Right. Know your audience. So if the kiddo's 4 years old, then, you would let them play with the equipment, touch it. Here, listen to my heart. Let me listen to your heart. So that those types of things. So basically, at what stage do you do those? Do you engage them into play and to get what you need out of the situation? So, they don't know what's going on, but if they ask you, say you need to give them a shot, is this going to hurt? Don't lie to them. Say, yeah, this is going to hurt. Not, well, it depends on what your pain tolerance is. To me, they have no idea. So, do elderly people, as they get older, are they more or less sexually active?
More.
Exactly. So, just because they're old, not dead, just FYI.
I would see complications there, but we won't go into that. But
go to the nursing homes. They'll sit there and
The
tell you.
nursing home.
Huh?
That's what I was going to say. I worked in a nursing home. Believe me, they're active.
So, just because you thought your grandparents weren't doing anything, then shame on you. They're probably back there knocking boots.
All right, let's leave my grandparents out of it.
I know they're touchy-feely, but I never would have thought, because of just body mechanics, that would be occurring, I guess.
I mean, they still have the interest in whatever method they choose to satisfy that.
Yeah.
I was going to say, there's an insane amount of penile implants out there.
So, I'm just basically saying, just because they are elderly, it doesn't mean that those desires have shut off. That's all I'm basically saying. So those desires are still there. So that goes back to the human development. But we do tend to think of, hey, they're elderly and that ship has sailed, and they're like, the ship is still going. So, and then think about the people who are actually active. And, there was some 80-year-old that was running marathons. So, they're not walking around on a cane, bent over. So just kind of, food for thought. So it's 9:07. I saw the message that Miss John sent out to you guys saying your test has been moved, right?
Yep.
Oh, okay. Don't squander it away. So I would continue to study. We will be hitting fluid and electrolytes really heavy on Tuesday. So don't come in dragging like you took the test on Monday.
So is there a reason why they keep getting postponed?
There's not necessarily a reason. I think, she and I talk, and it's really for your benefit as
Right.
as you're studying for two separate levels. To try to take a test in 3 weeks and you're trying to figure out the system, et cetera, et cetera, et cetera. To me, I just felt it was more stressful. But I mean, I can tell you're ready to take a test on Monday. I mean, it doesn't matter to me.
I'll take my time. Thank you.
So, I mean, the remaining two can't be postponed. We had a little bit of flexibility in the schedule. And it was just more of giving you the opportunity to be as successful as you can be. That's what it really boils down to. Yeah, if you have an extra week and it helps you, then so be it. I will say that in quite some time, regardless of what your grade was, or you may have wanted a better grade or whatever the case may be, the average mean for that test, I think I said was a 79 or 81 or something like that, hadn't been seen in quite some time. Not for the first test. So
Is that a good or a bad?
that's actually good.
Oh, okay.
So that, that's why I'm saying you may not have gotten the grade you wanted, but nobody made less than a 70. So it's all repairable. It's not, you know, don't get stuck on the number. Just continue to focus on, you know, making sure that you do well.
Well, I thank you for your time.
Yes, we thank you.
Not a problem, guys. All right, we'll see you on Tuesday. Be wetty.
Thank you.
Bye.
All right, good night.